to have a group of very established and distinguished guests, including Dr. Mudassir Hussain, who's a consultant pathologist, Professor Amar Anwar from Harvard University, who's a associate professor of radiology, especially in liver transplantation. And we have a national hero, Professor Faisal Saud Dar, who's done over 2,000 living donor living transplants and probably is one of the most gifted surgeons Pakistan has produced. We also have Professor Daniel Palmer from Northwest Cancer Care in Liverpool. So we're going to start the session by inviting Dr. Mudassir Hussain, who's a consultant pathologist at Shaukat Khanum Cancer Memorial Hospital, Lahore. He has over 60 publications, and we consider him one of our leading pathologists in the diagnosis of cholangiocarcinoma. And he's going to talk to us about the recent guidelines and the pitfalls in the diagnostic of this difficult cancer. Dr. Mudassir.
Okay, really sorry. So first of all, I'd like to thank Dr. Irfan for inviting me here in this glorious symposium from the last many years. And of course, in future, this tradition will continue. So cytopathology in the biliary region is, of course, it's very easy. It's not difficult. If you have to diagnose only two lesions, one is benign, other is malignant. The rest of the things, they are just, of course, nightmares. So recently, WHO has given guidelines for the cytopathology diagnosis in the this biliary area. So there are actually 7 categories from 1 to 7. And the first one is the insufficient. The second is benign or negative for malignancy. Third one is atypical, then pancreatic biliary intraepithelial neoplasia, which is low grade. Fifth one is high grade, suspicious for malignancy, and the malignant. So all these categories, they have their own estimated risk of malignancy, and there are, of course, clinical management options for every category. So in the first one, first we diagnose when there is no material at all. So there is some mucin, there are some only the hemorrhage, there are some cystic contents. We call it as insufficient. So there are no lesional cells. Maybe there is nature of the lesion, experience of the operator, and there are no established number of cells in the biliary area, where in the thyroid cytopathology, we have established number of cells. Whenever there are at least 7 groups or 10 cells in one group, we can call it as adequate number of cells. But in the biliary area, there is no cells, no established number of cells for adequacy. Sometimes technical issues, drying artifact can cause this category. Fibrosis in the solid tumor, or there is some contamination. So here you can see that there is only mucin. Sometimes we see in the slides only mucin, there are no lesional cells, so we'll call it as insufficient or inadequate for diagnosis. If the lesion is only cystic and there are no epithelial cells, this is hemorrhage, and there are some macrophages, we'll call it as insufficient, and this is only the cystic contents. Management is depending on the cause of this category, insufficient or inadequate, and usually we call it for repeat of the ERCP, FNAC, or biopsy in most of the cases. So category 1 is benign. When we see only the benign cells, there are no malignant cells at all. In the acute cholangitis, primary sclerosing cholangitis, or IgG4 related sclerosing cholangitis, there are no malignant cells, and we'll call it as benign category. So here you can see that there are lots of polymorphs, neutrophils, and in the background there are epithelial cells. So this is acute cholangitis. So this is a category 2, which is benign. Here, this is biliary epithelium. There are some lymphocytes, there are some plasma cells. So this is a chronic cholangitis. So this is another benign lesion. Management is depending on the patient's condition and the lesion specific. So now actually the story starts actually. Now, some of you guys will feel headache in your, of course, I think some pathology colleagues. So in the atypical category, usually we have seen benign cells, but there are few areas where we see the atypical cells are sometimes looking as malignant cells. Sometimes technical factors can cause this category, artifacts, or if there is no rapid on-site evaluation, then this category can be diagnosed. Histopathological outcome of in this category may be benign, may be pre-malignant, or may be malignant. So you can see that these are the biliary epithelial cells. If some person is inexperienced, they can call it as malignant. But from one side to the other side, there is no pleomorphism in the cells. Cells are enlarged. There is some prominent nuclei, but they are of same shape, same size. They are atypical. Maybe this is on account of acute cholangitis, or we cannot see the neutrophils in the background. But cannot be called as the malignant. These are the reactive epithelial cells. So here you can see also there is some loss of the polarity, some mild overlapping, mild mitosis, but we cannot call it a malignant, but they are atypical cells, can be in the vicinity, can be malignancies present. Atypical should be used wisely, since this lead to unnecessary investigations or procedures. Sometimes reactive cells are inflammatory cells. We cannot differentiate between them, so we'll call it as atypical. There is overlapping morphology in the cells whenever there are the history of stenting, stones, inflammation, or there is low-grade adenocarcinoma. Risk of malignancy is not less actually. In this category is 25 to 77%. So we must be very cautious when we are giving this diagnosis. Management, first thing is we must discuss this case in MDT. There must be consensus review in the department, and the expert who are see more slides, they should see this case as IDC, interdepartmental consultations. And usually there is repeat of ERCP and sampling with the rapid on-site evaluation. So fourth category is biliary intraepithelial neoplasia, low grade. Fourth and fifth category, radiologically they are the same lesions. Whenever there is low grade dysplasia, we call it category 4. Whenever there is high grade dysplasia, we call it as category 5. May be associated with the primary sclerosing cholangitis, choledochal cyst, and sometimes anomalous union of pancreatobiliary ducts. So this is biliary intraepithelial neoplasia, low grade. Here you can see that there are some cells which are showing hyperchromasia, but there is only mild pleomorphism. There is no high grade dysplasia. So we'll call it as biliary intraepithelial neoplasia. Usually these lesions, they are showing as a cystic lesion radiologically. Low grade biliary intraepithelial neoplasia is a flat or micropapillary lesion with mild increase ratio, focally distorted polarities, intraductal papillary neoplasm of the bile duct, IPMN, and mucinous cystic neoplasia. They are seen in the pancreas, but they can be seen in this region. So their criteria would be the same. So this is the histological picture of biliary intraepithelial neoplasia. So you can see this is the epithelium, and there is some overlapping the cells, and there is some prominent nuclei, but there is no high-grade dysplasia, no marked loss of polarity, no marked anaplasia, no mitosis. So this is biliary intraepithelial neoplasia, which is low grade. So ancillary tests can help us if there is diffuse nuclear expression of S100. We can call it as low-grade biliary intraepithelial neoplasia, and in the reactive epithelium, there won't be any expression of S100. Diffuse expression of P53 and loss of SMAD4 suggest cholangiocarcinoma over biliary intraepithelial neoplasia, low grade. high grade category and the low grade, only there is difference of dysplasia. Typically develop in the larger hepatic ducts, primary cholangitis may be the cause, hepatolithiasis may be the cause, liver fluke infestation, or choledochal cyst. So as compared to previous picture, we can see that there is low-grade dysplasia, but here you can see that every cell is neoplastic. There is, of course, significant loss of polarity. There are mitosis, hyperchromasia, overlapping. So all the criteria of carcinoma can be seen in the biliary intraepithelial neoplasia high grade. So this is category 5. So now the question arises how we can differentiate between the high grade biliary intraepithelial neoplasia and cholangiocarcinoma. Just logically, there is presence or absence of stromal invasion to differentiate between two. But surgical resection is the treatment of choice in the both lesions. Presence of mass lesion, if on the imaging we see mass lesion, invasive architecture is present, it is logically, we can call it as cholangiocarcinoma. If there is cystic mass and there is no invasion, we'll call it as biliary intraepithelial neoplasia high grade. So ancillary testing or studies, diffuse p53 overexpression is seen in only 10% of the biliary intraepithelial neoplasia high grade, while 80% of the cases of the cholangiocarcinoma show us diffuse p53 expression. So this is another differentiating point. Management, if patient is surgically fit, so high grade biliary intraepithelial neoplasia, the category 5 should be considered for surgical resection. So this is, of course, it's a more intriguing or more complex lesion actually, which is the category 6, suspicious for malignancy. In the atypical category, more benign cells were present and less malignant cells were present, or less atypical cells were present. In this lesion, more malignant cells are present, but in the background, there are few or less benign cells. Spectrum of feature on the one end is benign. If we see in the one end is benign, other end is malignant. Benign, atypical, suspicious for malignancy, and the malignancy. Category 2 is benign, category 3 is atypical, category 6 is suspicious for malignancy, and last is the malignancy or cholangiocarcinoma. This spectrum is nearly continuous without obvious cuts or subcategorization. In the one slide, we can see maybe sometime all these categories. So this is basically experience of the cytopathologist. So where we put one lesion in one category. So of course, so it's sometimes complete chaos when we see this slide, where we should put it, either atypical or suspicious of malignancy. Always see slides when you are fresh. See with the fresh mind. So you can see that there are, of course, there are these patches. They are obviously malignant looking cells, malignant looking areas. But there are few areas, or rather significant areas in the background, which are over there. I think this maybe not properly working. So over there, so these are the cells, maybe reactive, maybe benign. So in the front, we can see that these are the malignant areas, but there are some changes, of course, in the background cells. So this is a suspicious for malignancy in the category 6, actually. So if we know how can we diagnose atypical and suspicious for malignancy, we can easily diagnose what is benign and what is malignant, which are the, I think, easiest diagnosis, benign and malignant. The rest of the things are, of course, they are difficult. Sometimes difficulty in the sampling, varying experience of the endoscopist or the cytopathologist can lead to these lesions. Suspicious for malignancy, cytopathologically findings are highly concerning, but not the properly or completely diagnostic for malignancy. So if there is pancreatitis in the background, stents are placed, stones are present, or there is sucrosing cholangitis, so we are in a problematic phase of calling it as suspicious for malignancy, rather a complete malignant lesion. Risk of malignancy, of course, is not less, it's 80 to 100%. And is This lesion is not the result of to offer patient new adjuvant therapy or the radical surgery. Must be correlated in a treatment. In the MDTs, of course, these lesions are every lesion should be discussed in the MDT before any management. So the last lesion is, of course, is the easiest one, which is completely malignant. Is a primary malignant epithelial neoplasm arising in the bile duct epithelium. Ducts usually are most accessible, and usually they are arising in the extrahepatic ducts, but intrahepatic ducts are also the site of these malignancies. Risk factors include sclerosing cholangitis, bile duct cyst, hepatolithiasis, and Crowley disease. So here you can see that every cell is malignant. In the background, there are no benign looking cells. Every cell is malignant. There are overlapping in the cells, hyperchromasia. So all the categories, after seeing all these categories, we can see that these cells are, of course, there are no feature of any benignity in these cells. So loss of honeycombing, nuclear pleomorphism, and isonucleosis. So these are the things which are present in the adenocarcinomas or cholangiocarcinomas, cytoplasmic mucin, prominent nucleoli. Management is currently only means to achieve long-term survival, but unfortunately, only 15 to 20% of the patient present in a resectable disease. For those with the locally advanced diseases, systemic therapy with or without radiation is indicated. So at the end, so there are 7 categories. Every category has different estimated risk of malignancy and the management options. So from insufficient to malignant, so we have to put all the smears, all the slides into the different categories according to our experience and the type of cells. So take home message, pathologists must ask for more material when he or she in the rapid onset evaluation, if they are not comfortable for calling any lesion. Never jump to the diagnosis at the time of rapid onset evaluation or adequacy. So there is no need to jump. Our responsibility at the first slide is adequate or not. Evaluate scans and history before any evaluation of the slide. And of course, pathologists must know their limitations. So what is their limitations? This is also true for everyone, that we must know our limitations. Thank you very much. Thank you.
Thank you very much, Dr. Mudassir. We're going to take questions at the end.
Thank you.
So this basically presentation signifies what we normally face in real life. In the books, everything is black and white. It's either benign or it's malignant. But in real life, more than 80% of the time, we're trying to make a decision between, is this cancer, is this not cancer? And we don't really know the answer. And therein lies the problem with cholangiocarcinoma. So just to talk about the radiological problems that we face in the diagnosis and the management for cholangiocarcinoma, I'm going to invite Professor Amar Savar, who's an associate professor of radiology at Harvard Medical School, Boston, USA, and has got extensive experience with radiology in HPB. So it would be interesting to hear what pitfalls do they face in the management of this difficult cancer.
Thank you very much, Dr. Irfan, for the invitation. Appreciate the invitation to speak. These are my disclosures. So I'm going to give an overview of cholangiocarcinoma from a radiological perspective. I'll talk a little bit about anatomy and epidemiology. And then I'll speak briefly about principles of imaging, some interventional techniques, and how imaging can help both with surgical resection and after surgical resection. And then finally, I'll close out with some therapeutic options that we have with radioembolization. And so I think when we think about cholangiocarcinoma, it's important to think about all different types. There's obviously the mass forming type, which is typically very easy to diagnose, easy to see. But really the intraductal or the periductal infiltrating cholangiocarcinomas are very difficult to diagnose, both from an imaging standpoint as well as from the standpoint of pathology, as was explained by Professor Mudassir before. Unfortunately, the incidence and annual mortality rates of cholangiocarcinoma are increasing worldwide, particularly in Asia. And this is why this is an important cancer to think about. There's no good screening techniques. It's a very rare cancer, but it's also very deadly, especially if it's not resected. When we think about principles of imaging, there are several different imaging techniques that are very helpful for cholangiocarcinoma. Step number one, having a multiphasic CT of the abdomen and pelvis helps with local and distant staging and helps in determining resectability, especially as it relates to vascular involvement. Magnetic resonance cholangiopancreatography, or MRCP, helps identify biliary anatomical variants, which can be helpful for surgical planning. And then the CT chest can help stage the patient in detecting metastases. Compared to other cancers where PET-CT or FDG PET-CT is commonly utilized, PET-CT is of limited sensitivity but high specificity and can only be used on a case-by-case basis for this particular cancer. I will say that if it is clearly cholangiocarcinoma, we still need a biopsy. If we see something on imaging and we call it suspicious for adenocarcinoma, we still need a biopsy. And sometimes these diagnoses can be very challenging as you're trying to do rad-path correlation in a multidisciplinary tumor board. So when we think from a radiological perspective, as well as a surgical perspective, what is the classification or the staging for the cholangiocarcinoma? The most common classification type is the bismuth correlate classification. These are the different types. And these are helpful if a radiologist is aware of these as they're reporting these exams to differentiate between type 1, type 2. And the most critical finding is whether the cholangiocarcinoma or the area of haziness or the area of obstruction is extending up to the first branch point of the right hepatic duct or the left hepatic duct, because that will typically differentiate patients who are resectable from those who are unresectable. So here's a case example that kind of explains why it is very difficult to diagnose cholangiocarcinoma purely on the basis of imaging. So on the left, you can see a portal venous phase of a contrast-enhanced CT. There's a very ill-defined dark gray over here in the hilum. The main finding is the dilation of the bile ducts, both on the right side and the left side. And that kind of points us to the fact that there's something abnormal here, even though to the untrained eye, this could be very similar in appearance to the rest of the liver parenchyma. If you get a 15-minute delay and you have a large cholangiocarcinoma, usually most of these will enhance because of the fibrous stroma that are present within these tumors. And so you can here see delayed contrast enhancement on a 15-minute delay scan, but this is a very uncommon finding. This is not a common finding. These are challenging cases to diagnose on imaging. Here's an example of another patient with bilateral bile duct enlargement. You can see that over here. This is, according to this image that was taken from the literature, this is the point of where the tumor is. And any of us who's reading this on a routine basis, if there was no dilatation, you would very easily assume this to be normal parenchyma. Certain radiological techniques on CT, such as minimum intensity projections, can help highlight where to look for the tumor. But again, what this helps with is that for the endoscopist or the interventional radiologist to target their biopsies in this particular region in order to get a pathological diagnosis, because that's what's going to ultimately lead to the final commitment. I think it's also important as we're interpreting these images for CT and MRI to look at biliary anatomy. Here's a infographic of the different segments of the liver. And so a normal anatomy, typically you'll have the right posterior hepatic duct coming off posteriorly. The right anterior duct usually goes a little bit above the right posterior and then comes down. And then here is the left hepatic duct, basically draining segment 2, segment 3, segment 4A and 4B, and segment 1 in the most common iteration also drains into the left hepatic duct. However, it is critical for a radiologist to be aware of the different biliary anatomical variants because the right anterior and the right posterior ducts, where they actually precisely drain, can guide the surgeon on how to manage their resection and to ensure that there's no biliary leaks. Over here, unfortunately, white on green isn't showing very well. I think the one anatomical variant that I would guide everybody to be careful of is the type 3A, where the right posterior duct is emptying into the left duct. That's one of the most critical ones that you want to make sure you shout that out in the impression of your report. Here's an example of some MRCP images. MRCP is a beautiful technique, non-invasively, to get a very good look at the bile duct. So here's an example of a normal MRCP. You can see the gallbladder here, the common bile duct bifurcating into the left and the right. Here's segment 1 duct coming in, and this is a normal pancreas. Here's an example of a patient with a small stone. Here you can see that variant that I mentioned, the type 3A, where the right posterior duct, instead of emptying into the right anterior, is now emptying directly into the left hepatic duct. So that's something that we want to call out. Other variants that we can see on MRCP images are the right anterior and the right posterior emptying together into the right hepatic duct and then down into the CBD. This patient also had a pancreatic divisum that was incidentally noted. And this is an example of a variant in which the right anterior, it's basically a trifurcation of the common hepatic duct into the right posterior, the right anterior, and the left hepatic duct. So MRCP images can be very helpful in delineating biliary anatomy, particularly for pre-surgical planning. In addition to the biliary anatomy, if the patient is a surgical candidate, and unfortunately, a lot of these cancers are diagnosed very late because there's no good screening mechanisms, there are no good risk factors, it happens to occur sporadically. Looking at the portal vein and invasion of the portal vein is important. In general, 65% of patients, most of them are going to have a classic anatomy. But if you see the trifurcation of the portal vein, or you see the right anterior portal vein emptying into the left posterior portal vein, that's something that you will typically see in our multiphasic imaging, and it would be important to point out from a radiological standpoint. So what are some general imaging features of unresectability? These typically include bilateral hepatic duct involvement extending to the level of the second ductal radicals, as I showed in those original images, so a type 4 bismuth correlate cholangiocarcinoma. Any encasement or occlusion of the main portal vein proximal to its bifurcation. I think occlusion of the main portal vein is seen very rarely, but if you see soft tissue on a well-done CT that is extending into the porta hepatis, I think that's something important to call out, especially if you're suspicious that it is involving the main portal vein. Atrophy of one of the liver lobes with encasement of the contralateral portal vein or hepatic artery is a very important thing. And then I'll share a personal story here. One of my maternal uncles had jaundice at the age of 60 and told me about it. And he said, I think I have hepatitis A or something. I was like, you should get some imaging done. And he was a physician himself. And he said, I got an ultrasound done. It was done by the best guy at our hospital, and the ultrasound was completely normal. Don't worry about it. And I was like, no, you have jaundice. You should get cross-sectional imaging. So when he got a CT done, we found that his left lobe had actually shrunken down and it was high up in his chest. So it would not have been visible from an ultrasound. And so basically you can have these shrunken lobes that are related to cholangiocarcinoma. So he ended up having cholangiocarcinoma. He passed away from it. But atrophy of one of the liver lobes is a strong sign that this patient has a malignancy. And often those shrunken lobes, especially if they're in the left side, are not visible on ultrasound. So getting cross-sectional imaging is helpful. Atrophy of one of the liver lobes related to the ductal radical involvement can happen. Again, that happens typically very late. And then involvement of the hepatic arteries or any of the vasculature can lead to unresectability. However, these days, I think with robotic techniques and advanced surgical techniques, a lot of these cholangiocarcinomas are being resected, and transplant oncology is also becoming a factor that is being used to treat these patients. I think from a radiological standpoint, in general, not just for cholangiocarcinoma, there should be standardized reporting that ensures that every single patient gets assessed in a standardized fashion. And then typically your multidisciplinary team gets used to looking at your report and knowing exactly where to look for different things. Tumor size is important. For periductal infiltrating tumors, it's typically rare that we're able to differentiate the size. But if you have a little bit of a mass forming component next to the intraductal component, you'll be able to see it. Mentioning any intrahepatic satellite lesions helps determine resectability. Looking at the involved bile ducts, whether it's at the biliary confluence, which type of bismuth correlate tumor it is. whether there's any variant biliary anatomy, any variant arterial anatomy, arterial, portal venous, or venous involvement, lobar atrophy or hypertrophy. And then if the radiologist feels that this patient doesn't have widely metastatic disease, there's no peritoneal nodules, disease is localized to one side, the bile ducts look like they could be resectable, then the future liver remnant becomes critical, because those patients may get a right lobectomy or right trisectionectomy, depending on what the size of the future liver remnant is. Looking for suspicious regional lymph nodes is critical, and then distant metastases or peritoneal carcinomatosis is important as well. So moving on to once you've made a diagnosis or you find that the bile ducts are dilated and you want to make a pathologic diagnosis, I think most of these patients will end up going towards ERCP because it's a natural orifice intervention. It doesn't require percutaneous drain catheter replacements, which can have an effect on the quality of life. But in patients who fail ERCP, either to bowel anatomy, the presence of duodenal diverticulums, the presence of ampullary edema or masses, or the presence of gastric outlet obstructions, then percutaneous therapy becomes an option. And so here on the right side of your screen, you can see an image of a very dilated ductal system. This patient has had a prior cholecystectomy, and you can see a catheter basically going into the right posterior hepatic duct. And you can see this level of obstruction down here. We would use a wire to try to cross this, and after we've crossed this, doing brushings and biopsies would help establish the diagnosis. PTBDs also help with identifying the level of obstruction, and they can be therapeutic for patients who are not surgical candidates and have malignant strictures in terms of performing biliary stenting. The success rate of percutaneous biliary drainage is quite high, 97 to 98%. It's a slightly lower for patients who have non-dilated ducts, and this happens. This becomes especially important after surgical resection. If there's any biliary leak, those can be very challenging cases to do. However, the success rate reported in the literature is pretty good, and I think in expert hands it can be safely done. When we're performing percutaneous biliary drainages, I think it's important to think about the various complications that can happen. I think two areas to think about are, I'm not sure why this isn't working too well. Okay, so when you're putting your needle into the liver and you want to access the bile duct, I think it's important to access it peripherally, because if you access it centrally, and it's fine to access it centrally with a fine needle to dilate up the bile ducts. Thank you. But if you want to place a drain like an 8 French or a 10 French drain, then you want to re-stick in a peripheral zone, because in this area, there's a lot of important vasculature that can get damaged. In addition, when you're accessing the ducts, it's important to go over the rib, because the neurovascular bundle is sitting underneath the rib. And the final piece is that try not to stick very high up, because the pleural reflection is coming down, especially when you're doing a right-sided PTBD. This is why some people prefer to do a left-sided PTBD. The subcostal approach is actually more comfortable for patients compared to the intercostal approach, but the left ductal approach has a higher rate of hepatic arterial complications because the hepatic artery is superficial to the bile duct, especially centrally. So I'll skip the portion on surgical resection. There's much more qualified speakers on that topic, but basically the goal of hepatic resection is negative margins, and hepatic resection is important because these patients will have the best overall survival. However, only 30% of patients are diagnosed at the resectable stage. Anatomic resection is typically associated with improved survival, and about 50 to 70% of patients will need a large resection, either a hemi or an extended hepatectomy. And so I think, as I mentioned before, this is where looking at the volume of the future liver remnant is important. After surgery, radiology is still helpful. If a patient's not getting better after surgery, we can help identify infections in the surgical bed. This patient had a large collection here in the subhepatic space, which is amenable to percutaneous drainage. Patients can have biliary leaks despite the best efforts of the surgeons if there's unidentified biliary variants or for other reasons. These patients require both percutaneous drainage of the collection as well as placement of a percutaneous biliary drain, or more commonly an ERCP. And then finally, patients who have common bile duct or common hepatic duct strictures that get a hepaticojejunostomy can develop benign biliary obstructions. The role of imaging in this case is to detect the bile duct narrowing early on, can be assessed by the atrophy of certain segments or certain lobes. And then these are the different types of anastomosis that we typically see. So these two are choledochostomies, and here you can see a choledochojejunostomy, the different variations of it depending on the extent of the resection. If biliary obstruction is seen, again, more commonly, these patients are treated with ERCP and placement of covered stents. Typically from an ERCP approach is very helpful. From an IR approach, usually we would prefer to place, instead of placing a stent, we prefer to use balloon dilatation. And the reason for that is that because the patency of the stents is very low and the percutaneously inserted stents are typically not retrievable. But one of the challenges with balloon angioplasty of these strictures is that these strictures are typically very fibrous. And so they have a large degree of recoil. And so at our center, usually our typical management of a patient with benign biliary stricture is we initially do the percutaneous biliary drainage. We usually do some brushings to make sure there's no recurrence of the malignancy. But then we do 3 or 4 sessions of balloon dilatation of those benign strictures in order to make sure that there's no recoil and there's long-term patency. And our success rate has been about 80 to 90% for those patients who failed ERCP and then came to IR for percutaneous biliary management of their benign strictures. Finally, very briefly, I'd like to speak about radioembolization. Recently, there was a phase 2 multicenter trial of performing radioembolization along with gemcitabine and cisplatin for patients with cholangiocarcinoma. The primary outcome was a RECIST response rate, and the secondary outcome was adverse events, progression-free survival, and overall survival. Essentially, the disease control rate at 3 months was 98%. The progression-free survival was 14 months. The median overall survival was 22 months. But I think the most encouraging thing out of this trial was that about 22% of patients were downstage to surgical resection who were not initially candidates for surgical resection. I do want to be clear that this was mostly patients with mass-forming or intrahepatic cholangiocarcinoma and not with the extrahepatic cholangiocarcinoma. The grade 3 side effects were low. Most of these were neutropenia or thrombocytopenia. Most of these resolved on their own. Hepatic failure occurred in cirrhotic patients in particular, and so those are patients that we want to be a little bit careful with when we're performing radioembolization. So I think both this trial, which showed that 22% of patients were downstaged in a prospective phase 2 study, as well as multiple other studies that have been now published, including those from our own center, show that performing radioembolization in patients with cholangiocarcinoma is associated with survival benefit, primarily by multidisciplinary care, by making sure that those patients get downstage to resections who are not candidates for resection up front. And so finally, in summary, I would say that radiology has a critical role in optimal pre-procedure imaging. I would recommend structured reporting after discussing with the surgeon and the multidisciplinary team in order to make sure that everybody's on the same page when the report comes out. I think imaging and image-guided interventions can help with post-treatment complications. And I think that in mass-forming cholangiocarcinoma, radioembolization has a developing role in downstaging to resection. Thank you very much.
Thank you very much, Amar. We'll take questions in the end. So next, I will invite Faisal Saud Dar on the stage, who's a friend and a colleague. He does not need any formal introduction. He's a renowned liver transplant and HPP surgeon, both at national and international level. He's currently serving as Dean of Pakistan Kidney and Liver Institute. He led the development of national guidelines on higher cholangiocarcinoma, which is going to share with us today. Faisal.
Thank you very much, Irfan and Shaukat Khanum, for your kind invitation. I'm honored to share the national guidelines which we developed a year ago. So basically, as you have listened from the previous speakers, cholangiocarcinoma, especially the hilar cholangiocarcinoma, is not a very common cancer. It is a very difficult disease to diagnose. Most of the patients present at a very late stage and are not amenable to therapeutic surgical resection. It is quite resource intensive cancer in terms of either a curative treatment or even for the palliation of her symptoms. And there are very few centers in the country which can provide a comprehensive care for a patient with hilar cholangiocarcinoma. So hence there was a definite need to develop our local guidelines. So since I have been practicing HPB the last few years, I have been going to different national conferences. So the understanding of hilar cholangiocarcinoma among the clinicians was extremely very poor. And even on the specialist centers, the understanding how to manage this cancer as a multidisciplinary team was actually very poor. So that was the need that we must develop some national guidelines. So we at PKLI, along with Pakistan Association of Study of Liver Diseases, and in collaboration with all the major hepatobiliary centers in the country, we tried to organize a consensus conference at our institute in May 2023. So all the aspects of the hilar cholangiocarcinoma, starting from epidemiology up to the best supportive care, the whole topic was divided into different 15 to 20 topics. All the national experts in the field was given a topic to prepare, ideally with the support of whatever the best local literature is available. Otherwise, they could have international literature. So on the day of the consensus conference, there were about 15 speakers and other 10 national experts. So we debated each and every topic. And once the conference was over, a manuscript was drafted, and then it was shared with all the speakers and the experts. So over the next 3 to 6 months period, we developed this consensus conference into a manuscript, which was eventually published in the World Journal of Gastroenterology in March 2024. So that's the crux of the guideline, which I'm going to present over here. The evidence base used to develop these guidelines was from the Oxford Center of Evidence-Based Medicine. So the level of evidence and the grade of recommendation was according to this. So first of all, as it has been alluded earlier, that it is a difficult cancer to diagnose. Even if you try to find the literature about hilar cholangiocarcinoma, it is difficult because the international coding for diseases has not actually separately coded hilar cholangiocarcinoma till their latest edition, which is ICD-11. Before that, it was all grouped as intra or a distal bile duct cancer. So it is very difficult to actually pull out the evidence for hilar cholangiocarcinoma. But now we do have a separate code, so hopefully in the years to come, it will be easy to pull out the literature about this disease. Regarding the etiology, as we all know, choledochal cyst and primary sclerosing cholangitis and parasitic infections and stones in the bile ducts has been the well-established risk factors for cholangiocarcinoma. And increasingly, with the changing lifestyles, we do see that diabetes, alcohol, smoking, and obesity are associated with hilar cholangiocarcinoma, but they were thought on the basis of the evidence, they were thought to be the less established risk factors. In terms of histomorphological classification, we have seen an excellent presentation for 20 minutes, but this is just a snapshot of our recommendation that hilar cholangiocarcinoma histologically should be classified as either a conventional adenocarcinoma or unconventional tumors based on either the cytology or the pathology, whichever is available. Again, to standardize the reporting of hilar cholangiocarcinoma, the College of American Pathologists guidelines should be followed. And lastly, immunohistochemistry obviously can be done whenever you feel there is an additional need for interpretation of the diagnosis. In terms of laboratory evaluation, CA19-9 is widely used as a tumor marker, but it has a very high sensitivity, but should be interpreted very carefully, especially in jaundice patients. And we do see increasingly IgG4 cholangiopathy in these specialist centers, which can be confused with a hilar cholangiocarcinoma. But the testing, because doing IgG4 levels is expensive, is not freely available. So I think it should be done only in a selective cases wherever there is a suspicion about the cholangiopathy. About the imaging workup, it has been very nicely explained earlier, but you definitely need a cross-sectional images to diagnose. It can be a CT scan or a MR based on the availability, expertise of the center. Some centers are heavily CT dependent, the other do MR as their first choice of investigation. So whichever your institutional practice is, that can be done. MRCP obviously is always a very useful adjunct to not only define the stricture, but also it helps in planning your surgical resection. Secondly, hilar cholangiocarcinoma do have some characteristic radiological features. And based on those features, with the discussion in the multidisciplinary team, you can actually confidently diagnose hilar cholangiocarcinoma. A PET scan, again, is a very useful adjunct in terms of the staging of hilar cholangiocarcinoma, but again, it's not widely available. However, in terms of a treatment planning, if there are any suspicion on the CT scan, PET scan can be done and it may upstage the disease, especially in case of a lymph node involvement. The endobiliary procedures in terms of diagnostic evaluation, wherever possible, ERCP guided either cytology or a biopsy should be done. However, the histological diagnosis, we thought, based on the evidence available, is not absolutely mandatory. So if the radiologist and the multidisciplinary team is convinced, then you can go ahead with a surgical resection. And this is not only our guidelines. There has been a UK guidelines published about a year before our guidelines. So I think getting a biopsy is difficult. And even doing a biopsy, getting a tissue sample is difficult. And whenever you get a sample, the pathologist is never happy that the sample is enough. So there is no point in running into one ERCP, second ERCP, and the third RCP. I think the radiology is that sensitive these days. If in MDT you are convinced, we should go ahead with a surgical resection. However, if the patient is going through an ERCP, for otherwise like jaundice, sepsis, pruritus, or whatever, then obviously there should be an attempt to get cells or the biopsy. And the number of passes should be increased. And normally they say at least 10 passes with the brush at the time of ERCP. And our own data from PKLI actually suggests that if you have done 30 passes, actually getting the sample you get the sample in about 90% of the time. But doing 30 brushing take a lot of time. It's a lot of breakage in the brushings. It is resource intensive. So I think 10 is the average. And then intraductal cholangioscopy and a biopsy, of course, can be done in a very selective cases, as we do see IgG4 cholangiopathy, autoimmune hepatitis along with a sclerosing cholangitis, and some cases of a primary sclerosing cholangitis where the diagnosis is not really clear. The patient are jaundice, but you don't see a dominant stricture. These are the patients where a cholangioscopy and the biopsy is really very helpful and actually should be done. If on a CT scan, there is a concern for metastasis, especially the regional metastases, which are amenable to endoscopic ultrasound and a biopsy. I think they're the best way to stage the lymph nodes. Otherwise, PETs can be an alternative. Sorry, in terms of the staging, there are about 6-7 staging systems used internationally for staging the hyalocholangiocarcinoma. But looking and going through all these staging systems, we came up with these 3 staging systems. So pre-operatively, I think the extent of the biliary involvement, thank you, is best described by Bismuth-Charlotte classification. So this remains the standard and probably has the best piece of evidence so far that it should be used for staging hyalocholangiocarcinoma. But the limitation is it does not describe the vascular involvement, atrophy of the liver, and the future liver remnant. And these are all important for a decision making. So hence the Memorial Sloan Kettering Cancer Staging System, which further describe the involvement of the vasculature or the liver atrophy or the future liver remnant. That should be part of your planning. And post-operatively, when you have the histological sample and the lymph nodes, then the TNM staging system should be used. And that actually helps in terms of predicting the prognosis after curative surgery. The assessment of resectability, as I said, should be done as a part of the MDT. But even at times, the MDTs are difficult because MDTs are all driven by the individuals. So it actually depends who is sitting in the MDT. And the extent of a surgical resection or resectability is so variable. At times, it's in some MDT, it's a radiologist determining the resectability, and in others, it's the surgeons. And even among the surgeons, the extent of surgical resection and the definition of resectability actually varies a lot. So I think the best possible forum is actually MDT, where a lot of professionals can sit together and determine the resectability. Portal vein embolization is an important adjunct in terms of making these patients resectable, where the side which has to be removed can be embolized so that the future liver remnant gets a hypertrophy in the next few weeks. But the disadvantage of that is there is always a risk of a disease progression in the next 6 to 8 weeks. And the other thing is, if the future liver remnant remain obstructive and cholestatic, it's not going to hypertrophy. So, but portal vein embolization can be selectively used in patients where the surgeon believes that doing a portal vein embolization will increase the chances of resectability. Preoperative biliary drainage has been very controversial. Unfortunately, this was one of the main reasons to develop the guidelines, because most of our patients end up in a gastroenterology clinics, and the first thing they get is a ERCP and a stent. And then if the tumor is small, in the presence of a tumor, interpretation of the CT and MRs become really difficult as well. And most of these patients with the ERCP interventions get their biliary tree contaminated and later on get sepsis post-operatively. So I think we wanted to discourage doing ERCPs without discussing at the MDT. So the piece of evidence which we come up that ERCP and a stenting should not be done until unless a jaundice patient has cholangitis, there is a need for adjuvant chemotherapy, or a patient have a severe pruritus, you are thinking of a portal vein embolization, and all these things. And then the way you are going to decompress the biliary system, I think, as Amar has already alluded, ERCP is probably the best way, especially for bismuth 1 and 2. For bismuth 3, again, depending on the expertise of the center, the abilities of your endoscopist, at times you can selectively stent in bismuth 3 as well. However, in bismuth 3 and 4, PTBT can also be considered. Surgical resection remains the gold standard or the only hope of a cure if it is possible. So whenever a patient is considered or deemed surgically resectable, they should have, that's the hilum and the bile ducts, the complete excision of the biliary tree, the side of the liver where the disease extent is more, and the caudate lobe. This should be all excised to get a radical clearance of the cancer. Frozen section, if available, can be done because at times the hyalocholangiocarcinomas spread longitudinally, and you may find a very clean bile duct as your transaction margin, but actually the disease have a microscopic invasion at that level. So hence you might have to do pancreatic duodenectomy or a further liver resection if you get a positive margin. And very occasionally, you keep on resecting, you do a pancreatic duodenectomy and a hepatectomy, but still you end up with a positive margin that you have to actually pull out at that point in time. Liver transplantation remains largely experimental for hyalocholangiocarcinoma. The best piece of evidence so far has been from the Mayo Clinic, but the biggest criticism on the Mayo Clinic criteria that these results have never been reproduced by any center in the world. And there have been a lot of a selection bias if you go into the details of the Mayo Clinic's protocol. But however, in the recent years, there has been a reinterest in transplanting these patients for hyalocholangiocarcinoma. So patients who are surgically not resectable, but still within the Mayo Clinic criteria, should be considered for transplantation under the Mayo Clinic protocol. But the problem with the Mayo Clinic protocol is that it's not largely feasible in our country because of the radiation therapy, which has to be done as a part of this protocol. The centers who do transplant, they don't have these radiation therapies, and the centers who have the radiation therapy, they don't have a transplantation. So it's a very complex decision making. However, there still will be a very selective group of a patient who potentially can benefit from liver transplantation. But our recommendation was that upfront liver transplantation without chemoradiotherapy can be considered only as a part of a clinical trial. Adjuvant therapies, I think the next speaker is going to talk more about it. But for hyalocholangiocarcinoma, there has not been much advancement in the last 30, 40 years. Most of the times, it's 5-fluorouracil, capecitabine, gemcitabine. 5-fluorouracil versus nothing, gemcitabine versus capecitabine versus nothing. So that's all the piece of the evidence which we have, unfortunately, so far. But once the patient has a surgical resection, you have a better staging. So you divide these patients into basically high risk and low groups. High risk is the one who has either a R1 resection, that means there's positive margins, they have a lymph node involvement, they have a poor histology, vascular invasion, or a perineuronal invasion. So positive margin along with any of one of these factors will classify them as a high risk group. So for a high risk group, definitely you need to give them a chemotherapy. Their surveillance protocol is different. They should be followed up in the clinic every 3 months with examination, ultrasound, CA19-9. CT scan should be done every 6 months for the 5 years. For the low risk group who had a curative margin negative resection with none of these risk factors can be followed up initially every 3 months, and then CT can be done once a year for the next 5 years. And then the metastatic carcinoma, I think I will skip that because the next speaker is going to cover that. Largely, it is the chemotherapy, which definitely gives some survival advantage. And then the major group, actually, which we deal with, eventually we end up palliating them. And the biggest thing which need a palliation is actually jaundice. And again, that is something to really debate about. Most of these patients will require an ERCP or a stent, or PTBD and a stent. And the metal stents are really very expensive. Some of the patients actually comes to us with a resectable disease and a metal stent. And some of the patient comes to us with even a metastatic disease and a metal stent. So I think we are a poor country. Every institution has a limited resources. I'm sorry, just take 1 or 2 minutes. The nature and the mode of the palliation and even the stent I think either we need to educate our gastroenterologist or these decisions need to be made in a multidisciplinary meeting. Because if patient is jaundice, they have a metastatic disease, their median survival is less than 3 months. So there is no point in putting a metal stent in these patients. They should be just palliated with the least possible expense on their care. These are all the authors who contributed to the development of this manuscript, and I would like to thank all of them for their contribution. And thank you very much for your patient listening.
All right, Bismillahirrahmanirrahim. Before I introduce the next speaker, let me introduce myself. My name is Professor Farooq Afzal. I'm a professor of surgery and a principal at PGMI, Amiruddin Medical College, Lahore. And I was just late because I was attending a meeting on interprofessional education. So learning from interprofessional education back into a multidisciplinary management of highlighted cholangiocarcinomas and hepatobiliary research. So our next speaker is Daniel Palmer. He is not a surgeon. He's a professor of oncology in Northwest Cancer Care, Liverpool, UK. And his special interest is highlighted cholangiocarcinomas as well as pancreatic cancer. And he's going to talk about oncological perspective on current management of highlighted cholangiocarcinoma. So, Daniel.
I'm an oncologist, University of Liverpool, UK. I've privileged to be with you today to discuss recent advances in systemic therapy for cholangiocarcinoma. These are my disclosures. Biliary tract cancer is an umbrella term for several biologically and clinically distinct cancers according to anatomy, etiology, and underlying genomics. Globally, the epidemiology is variable, with some high-risk areas, particularly in Southeast Asia, related to chronic liver fluke infection. In the West, the commonest etiologies are primary sclerosing cholangitis and other forms of chronic liver disease, notably fatty liver disease and alcohol-related liver disease. And this underpins an increasing incidence of intrahepatic cholangiocarcinoma in the West. In Pakistan, there are no national registry data to give an accurate assessment of incidence. However, recognizing the major risk factor of chronic liver disease and endemic viral hepatitis and fatty liver, it's likely to be a common cancer. In terms of anatomical location, hilar cholangiocarcinoma is particularly challenging, given that it is typically not amenable to surgical resection. Tissue acquisition or definitive diagnosis can be difficult, and in order to safely administer systemic therapy, biliary drainage is required, and this often involves complex procedures to achieve adequate drainage and reduce the risk of sepsis, particularly when associated with myelosuppressive chemotherapy. Typically, despite these variations, a one-size-fits-all approach to systemic therapy clinical trials has been adopted, in which all subtypes are treated in the hope of deriving a beneficial effect across all groups. More recently, smaller subtypes defined by anatomy or more typically molecular profile that may benefit from more specific approaches have been adopted. Until 2010, there was no standard systemic therapy. In the preceding 25 years, a large number of studies have been conducted, but mostly small single-arm phase 2 studies with very few randomized data from poor quality small clinical trials. This changed in 2010 with the publication of the UK-led ABC2 clinical trial, which established cisplatin gemcitabine as the standard of care, with a significant survival improvement compared with gemcitabine alone, with an improvement in median survival from 8 months to just under 1 year. And notably, this benefit was seen in all important subgroups, in particular, according to anatomical location, with the same benefit seen in both intrahepatic, extrahepatic, hilar, and gallbladder cancers. Subsequent to this, much effort was made to improve upon chemotherapy, looking at more intensive triplet combinations or in combination with novel drugs, all adopting an all-comers unselected approach. One positive study from Japan looked at the addition of the oral fluoropyrimidine S1 to the GemCis backbone, but this hasn't gained any traction beyond Japan. The French study investigated modified FOLFIRINOX. This was a randomized phase 2/3 design but the study was halted at phase 2 analysis grounds of futility. In America, the addition of nab-paclitaxel to CISGEM was investigated on the basis of some highly promising phase 2 data with a response rate of 45% and a median overall survival of just over 19 months. However, disappointingly, this didn't translate into any significant benefit in the phase 3 setting. Some novel agents have been deployed, notably the Nucana study looking at a modified form of gemcitabine that is aimed at overcoming some of the key resistance mechanisms. This was a large global phase 3 study and was again disappointingly negative with no benefit compared with the standard cisplatin gemcitabine alone. A number of other studies looked in an unselected population at the addition of targeted therapies, largely targeting the VEGF pathway and also looking at multi-kinase inhibitors, also disappointingly negative with no improvement on the CISGEM standard of care. In the second line setting, again, until recently, there was no established standard systemic therapy. This is the UK-led ABC6 study, which was a randomized three trial investigating the addition of modified FOLFOX chemotherapy to active symptom control in patients who had progressed on prior first-line cisplatin and gemcitabine chemotherapy. And patients were stratified according to the sensitivity to the previous cisplatin, as well as some key prognostic factors. And this was a positive study in terms of overall survival, with an improvement with the addition of chemotherapy, a hazard ratio of 0.69. In terms of median overall survival, this was modest. However, looking at the 6-month survival rate, this was 35% in the no chemotherapy arm, increasing to over 50% of those in receipt of chemotherapy. And similarly, at 12 months, only 10% of patients alive without chemotherapy, increasing to 25% in those receiving chemotherapy. This was, again, a consistent effect across all subgroups, notably across all anatomical locations, and including those with platinum refractory disease. More recently, the focus has shifted to identifying molecular subgroups. This is on the basis of a large series of studies that have identified the variations in the genomic alterations underpinning cholangiocarcinoma and highlighting key differences according to the anatomical subtype, in particular with intrahepatic cholangiocarcinomas having a higher prevalence of FGF receptor fusions and IDH1 mutations, both of which I'll talk about in a little bit more detail later on. Extrahepatic cholangiocarcinomas having a high rate of KRAS mutation, but along with gallbladder cancers also having a higher rate of HER2 amplification. Actionable targets, including IDH1, FGF fusions, HER2, and other rarer abnormalities such as NTRK fusions and MSI with potential benefit for checkpoint inhibition. This is the Keynote 16 study that looked at pembrolizumab in the context of microsatellite instability in both colorectal and non-colorectal cancers. Here we see the colorectal cancer data with a significant survival benefit for patients with MSI high compared with those with mismatch repair proficient tumors. A small number of patients with mismatch repair deficient non-colorectal cancers, but encouraging survival and also responses. Here we see the waterfall plot, patients with mismatch repair proficient colorectal cancer essentially not responding to pembrolizumab, but those with mismatch repair deficiency, both in colorectal and non-colorectal cancers, showing encouraging response rates, including a patient with cholangiocarcinoma. And on this basis, pembrolizumab was granted FDA accelerated approval for patients with MSI high cancers. More specifically, in relation to biliary cancer, there is a rationale for checkpoint inhibition beyond MSI, and this is underpinned by the recognition that the cancers tend to occur in the context of chronic inflammation. Surgical series have suggested that patients with high levels of tumor infiltrating lymphocytes have a better prognosis, and PD-L1 expression is associated with poorer survival. A number of small phase 2 studies have investigated checkpoint inhibition confirming the keynote 16 data with good responses in those few with MSI high tumours, relatively modest response rates in those with mismatch repair deficient disease, but a potentially higher response rate when given in combination with chemotherapy. More recently, this has been demonstrated in 2 large phase 3 studies. This is the TOPAZ-1 trial investigating the addition of durvalumab to this gem backbone, with a statistically significant improvement in overall survival in this study, with a hazard ratio of 0.8. In terms of median survival, only modest increments with the addition of immunotherapy. However, a proportion of patients achieving longer-term survivorship with the addition of immunotherapy, with a 2-year survival rate approaching 25% with immunotherapy, compared with just 10% with chemotherapy alone. Like ABC2, this benefit was seen across all subgroups, notably including those with higher cholangiocarcinomas and gallbladder cancer. Very similar results from the Keynote 966 study investigating the addition of pembrolizumab to the cisgem backbone. Similar patient demographic in terms of the distribution of intrahepatic versus extrahepatic gallbladder disease, and similar rates of viral hepatitis as the underlying etiology, and very similar survival outcomes with a hazard ratio of 0.83 favouring the addition of immunotherapy, and a similar 2-year survival rate of about 25%. Of course, this suggests that a significant proportion of patients do have no significant additional benefit with the addition of immunotherapy, and this is likely underpinned by the largely immunosuppressive tumour microenvironment in biliary tract cancers, with cancer-associated fibroblasts, regulatory T cells, tumour-associated macrophages, and myeloid-derived suppressor cells, largely contributing to immunosuppression. But this provides us with a series of potential novel therapeutic targets which may increase the response rate to immunotherapy in the future. Moving to more targeted approaches, IDH1 mutations are commonly found in intrahepatic cholangiocarcinomas in particular, with a prevalence of about 20%. IDH1 have cancer-associated mutations which happen early in tumour development. And these mutations result in novel gain-of-function enzyme activity, which can block normal cell differentiation and promote tumorigenesis, but is liable to inhibition through specific IDH1 mutations. This is the Clarity study investigating the IDH1 inhibitor ivosidenib. Primary outcome measure was progression-free survival with a clearly significant effect, a hazard ratio of 0.37, favouring ivosidenib over placebo. The overall survival analysis is somewhat more complex. This was a blinded placebo-controlled study, but those patients on placebo were allowed to switch to ivosidenib upon progression, which somewhat confounds the overall survival analysis. So we see a more modest improvement in overall survival compared with PFS. However, a statistical analysis accounting for this crossover suggests a more meaningful benefit in terms of overall survival, indicating this to be an active drug in this setting and now FDA approved. FGF receptor is also a potential target, largely in intrahepatic cholangiocarcinoma. And a number of studies of different FGF receptor inhibitors have demonstrated very consistent positive activity in terms of response rate and progression-free survival. This is one example of pemigatinib in the second-line setting of previously treated cholangiocarcinoma in patients harboring FGF receptor 2 fusions or other aberrations. And here we see in the cohort with FGF receptor fusions, you see a significant survival benefit with the addition of pemigatinib, with a median survival approaching 2 years. However, in those patients with other FGF receptor aberrations, including mutations or amplifications, or in those patients without any FGF receptor aberration, we see no obvious impact in terms of overall survival, with a median survival of between 4 and 6 months. And again, on this basis, these drugs are now licensed for patients with FGF receptor 2 fusion harboring cholangiocarcinoma. Finally, targeting HER2 in biliary cancer. This is more relevant to the perihilar and gallbladder population. This is the Horizon BTC study investigating the novel HER2 bispecific antibody zanidatamab, which can simultaneously bind to two separate HER2 molecules in trans, with preclinical studies indicating greater activity compared with trastuzumab and pertuzumab. And this study looked at patients with HER2 amplification, and particularly looking at those with the 2+3+ amplification, population size of 80. We see very encouraging response rates with a response rate in excess of 40%. And these responses are durable, with median duration of response exceeding a year, and a very encouraging median overall survival of 15 months, this being in the second-line setting. And on this basis, this drug has also now been approved for HER2 amplified biliary cancers. A number of other studies looking at other agents targeting HER2 are looking similarly promising. This includes combinations such as trastuzumab, pertuzumab, also novel antibody drug conjugates, showing very encouraging response rates in excess of 50%, and also looking at combination with cisplatin gemcitabine chemotherapy in the first line. Again, very encouraging response rates of 80% and progression-free survival rates of 7 months, indicating this to be an active pathway in selected patients. In summary, over the last 15 years, there's been modest progress in systemic therapy for patients with advanced cholangiocarcinoma and gallbladder cancers, beginning with the ABC2 study in 2010 that demonstrated the benefit of cisplatin and gemcitabine chemotherapy. More recently, modest incremental gains with the addition of checkpoint inhibitors in unselected patients, but more work to be done to identify better strategies for harnessing the benefits of immunotherapy. And more recently, a number of molecular targeted approaches, notably FGF receptor and IDH1 inhibitors, particularly for those with intrahepatic cholangiocarcinomas, and HER2 targeted therapies that may be more broadly applicable to those with extrahepatic, perihilar, and gallbladder cancers. In terms of ongoing research now, studies are looking at the incorporation of these targeted approaches in earlier lines of therapy in combination with first-line chemotherapy, and also looking at their use in the adjuvant setting, where for those with resectable disease, the potential benefit may be greater. Finally, I'd like to acknowledge the funders of the ABC trials that I've described today, Cancer Research UK and the AMMF Cholangiocarcinoma Charity, and also the NCRN Biliary Tract Cancer Working Party, of which I was very grateful to be a part in terms of designing and delivering ABC studies. Finally, thank you for your attention. Shukriya.
Thank you very much, Daniel. So it was an extensive overview of hilar cholangiocarcinoma, which is quite a difficult disease to treat. But we'll open up the floor for discussion. We are well ahead of time, so hopefully we can have some thoughtful discussion about this disease. Any questions from the audience?
So Dr. Ali is going to have the mic, so you can take the mic around if possible to the speakers.
My question is from... Okay, so my question is from Dr. Amar. So why it was highlighted during the biliary anatomy that 3A needs to be highlighted to the surgeons? I understand it goes into the left hepatic, but why is it essential to highlight in the report or to the surgeon?
Thank you for that question. I think it's best answered by a surgeon. But generally speaking, if your resection plane is along the left hepatic duct and you don't recognize it, I think most surgeons, most expert surgeons who are taking care of these patients will recognize it. But you wouldn't be, you would assume that you're going along the resection plane and you miss the opening, that it can lead to a bile leak from the left hepatic duct. So again, rare issue in most experienced centers, but just something to point out.
Any more questions from the audience?
From Dr. Dar, the point is that you highlighted that IgG4 is more specific when we are suspecting any cholangiocarcinoma. But since we are also seeing that in autoimmune pancreatitis, so how do you differentiate the two then? Because it's also raised in autoimmune pancreatitis, which has the irregular enhancement on imaging as well. So the imaging features are overlapping. What is the question? So how do you differentiate? Is it cholangiocarcinoma or is it autoimmune disease?
I mean, you can't differentiate on radiology. All you see is a stricture. I mean, in terms of a cancer, you will see a mass. And based on the radiological appearance of that mass, the radiologist can comment that it is a cancer or not. But if it's just a stricture, then you don't know what kind of a stricture it is. Then obviously, based on the patient's histology, history, somebody is young, having symptoms of intermittent itching going on for 2, 3, 4, 5 years, a bit of a weight loss, a bit of diarrhea, you might be thinking about a PSC. So I think the history can guide you. That is one. But eventually, once the patient start getting jaundice, you can do all your autoimmune extensive screening, any of the immune marker is positive or not. But ultimately, I think you need to get a tissue sample. And the best way for these strictures is probably colonoscopy, spyglass, and a biopsy, because there is no real stricture. The ducts are not that dilated, and you have a very localized small stricture. So I think biopsy will tell you what it is. Yeah, if your pathologist is happy with the amount of a sample.
My name is Dr. Abdul Wahid. I'm an oncologist from RMI Peshawar. My question is for Dr. Daniel. Please to tell us that there is very good response of combination chemotherapy, gemcitabine and carboplatin we are using. Sometimes we use also FOLFIRINOX. Is there any role of liposomal cisplatin or liposomal doxorubicin in combination with pembrolizumab or gemcitabine, please?
Question from Daniel. Could you hear the question and could you respond to it, please?
Assalamu alaikum. Hopefully you can hear me okay. Good morning, everybody. May I say it's been a great honor and privilege to join you today. Really enjoyed my fellow speakers' presentations as well. And congratulations to Professor Dar and the team on your guidelines. That's a really great piece of work. In answer to your question, I guess that in terms of evidence-based phase 3 data, there are none. So the best data remains for the first-line combination of cisplatin and gemcitabine, and where available, the addition of immunotherapy. In terms of irinotecan-based treatment, I guess the best data we have is from the French study looking at FOLFIRINOX, which disappointingly was negative at the phase 2 stage. Obviously, that's a complex regimen with a high toxicity burden, particularly in patients with high cholangiocarcinoma, where, as we discussed, stenting issues are challenging and the risk of biliary sepsis is high. So there's a balance between potentially increased efficacy versus increased complications and toxicities. So at the moment, it would be difficult to recommend those formulations. I guess in other settings, including pancreas cancer, the nanoliposomal preparation of irinotecan is indicated in the nalirifox regimen, but even there, no direct comparison with standard irinotecan to know that how much added benefit, if any, the nanoliposomal preparation will give. So no current strong evidence to support that, I would say.
Okay, thank you.
Thank you.
Assalamu alaikum. I'm Dr. Izzat, fellow HPB and liver transplant surgeon from Sheikh Zayed. And my question is from Dr. Faisal Saudar. Sir, have you considered in your consensus guidelines that in our practice, I've seen patients who are deeply jaundiced, but on radiology, if they have resectable disease, we go in and do some sort of resection right or left. But these patients tend to decompensate in their early postoperative period that produce lots of ascites. Have you taken that into consideration that why not decompress preoperatively?
Thank you. I mean, you need to understand why the patient is having ascites. I mean, ascites is a manifestation of portal hypertension. So either you have removed too much liver and the remaining liver is trying to extensively hypertrophy, leading to, at times, this over-accentuated hypertrophy lead to sinusoidal obstruction and a portal hypertension. So you as a surgeon might think that you have left enough liver behind, but functionally that liver was not good enough. So that is one part. Secondly, ascites can be just because of the low albumin. Albumin on its own is a very good marker of your prognosis. So in our setup, we do see patients are actually very malnourished. So if they have a poor albumin reserves, that can be another reason for ascites. So I think putting an argument of decompressing the biliary system and relating it to the post-operative ascites, I don't understand that how they are linked together. Your pre-operative planning is obviously very important. The evidence which I try to put in there, that just going into a habit of stenting and bringing the jaundice down before surgery, it does not have any scientific basis for that, and it does not help. And out of our own experience, of the cholangios and even the pancreatic resections, which we have published, all of our patients who get biliary stenting and you do their surgery 2 weeks after the stent, you get 100% colonization. And that leads to prolonged ventilator stay, prolonged recovery, wound infections, dehiscence, collection, and all that. And actually, your most of the post-operative mortality and morbidity is related to these infections. So I think we are very cautious. If the patient is fit, this it's a clear-cut surgical resection, I would not be fussed about just bringing the jaundice down and then do a surgery. I will just go for surgery. I mean, I don't see a role of RFA in hilar cholangiocarcinoma, but I think there have been some studies, and the radiologists can comment better. You might have a dominant structure, surgically not resectable, and then the intraductal RFA, by the interventional endoscopist. There have been few studies and papers about that, but I am not sure how commonly it's done.
Thank you, Dr. Faisal. My question to you is excellent. I think the last 2 decades, we have seen Shaukat coming and now PKLI coming on the horizon. So excellent job you're doing. I like these consensus guidelines as well. I was the president of Society of Surgeons a few years back, and we tried to develop guidelines for some 4 common conditions, surgical conditions, which were general surgery use face. And when we developed the committees, what we found that there was a lack of local evidence, right? And when there's a lack of local evidence, then you have to go for the expert consensus. But when the same task was being done at Aga Khan, they followed the grade methodology, Garden Guide. My question to you is, what methodology? Did you go for the grade methodology workshop for the trainers or for the experts before you basically devise these consensus guidelines, or just their opinions, expert opinions?
But, I mean, we try to involve all the national experts. And obviously, we requested them to bring the piece of a local evidence. But if you try to find the local evidence, it's hardly any. There are hardly 3-4 papers. A couple of them are our center. I think one is from Shaukat and Khan. That is it really. And 1 or 2 about the epidemiology. So I think at the end of the day, it was the experts with most of the international literature and the practice among these expert centers, which we try to adopt in the, and that is why if you look at the a piece of evidence, majority of the evidence is actually 3 or 4 with strong or a weak recommendation. But that's the best possible which we.
Yeah, but now we are expecting institutions like Khanum and PKLI to develop our own evidences here. So I think maybe in coming few years, inshallah, we'll have enough local evidence to based on which we can create recommendations and guidelines. This is what I think.
We need to actually collaborate among these centers because this is a rare disease. The number of patients which we are like, we do about maybe 20, 25 hepatectomies for hilar cholangiocarcinoma, which for a center is a big number, but overall it's not a big number, So unless all the centers collaborate, maybe develop a registry for hilar cholangiocarcinoma and then follow these. So I think Shaukat Khanum as an institution is probably is the best posed. And actually, this is one of the discussions we had in that consensus meeting, that Shaukat Khanum should take a lead and develop a local registry where all the centers should contribute to the data. But out of the conference, Shaukat Khanum never took the lead, unfortunately, because they have the best basic structure and they have already developed otherwise registry. So I still believe they are the best one to start the registry for hilar cholangiocarcinoma.
Yeah, we were just discussing the interprofessional. I think interinstitutional collaboration is the key. And I think now we have to develop our local resources, especially in research, because if you want to have local data, you have to conduct the research. I think both of the institutions should be doing excellent job. Still, you're doing an excellent job. Thank you so much.
My name is Dr. Mohammad Ramzan. I'm an intervention radiologist at PKLI. I don't have a question, but my comment is that when we are doing portal vein embolization in cases where we need to increase the liver volume, we have done like few cases, not at PKLI in UK. If we do like portal vein plus hepatic vein embolization, we get the early hypertrophy of the other side. I don't know what the experts' opinion is in this regard. If we thinking of something which is marginal, why not to perform both together to save time?
I think there is evidence coming up that combining hepatic venous embolization along with a portal vein lead to more volume gain in a shorter period of time. But I think you cannot probably adopt that as a blanket policy. It has to be tailored according to that individual patient. And it should be all a part of the overall planning for an individual patient. For example, you may be embolizing a portal vein for someone who just need a right hepatectomy for the clearance of his cancer. And maybe you will be embolizing not only the portal vein, but also the segment 4 portal veins to have a hypertrophy in the left lateral segment. So I think this is a good adjunct, but has to be discussed on an individual case basis at the multidisciplinary level.
So I'm just going to make 2 questions. One's from Daniel, if he's still online. So Professor Daniel, looking at your presentation all the way from back when the EBC trial happened and coming all the way up to now, the overall picture hasn't really changed. I mean, in terms of survival, it has made some changes, but it's not been such a big jump that we've seen with breast cancer and say with melanomas and so forth. In your opinion, jumping down 5 years time from here, do you see anything on the horizon which might kind of improve things from an oncological perspective for us in terms of this cancer here?
Thank you for the question. You're right. Progress has been modest and incremental. I guess there are various reasons for that. One is these are relatively rare cancers. They're heterogeneous. And in the past, we've tended to treat them collectively, particularly with chemotherapy and more recently immunotherapy, without really necessarily selecting out the subgroups of patients most likely to benefit. That is changing in the era of the more molecular targeted treatments that I've described, particularly with intrahepatic cholangiocarcinoma. The data is more robust with FGF receptor fusions and the IDH1 mutations. But these are subgroups of subgroups, so these are relatively small numbers of patients. potentially a big impact for those individuals, but in terms of overall survival for the population with cholangiocarcinoma, will have a relatively modest impact. With immunotherapy, I guess, although positive trials, the gain has been disappointing in the unselected populations. The survival curves suggest that there's a subgroup of patients who do derive that longer-term benefit, but at the moment we don't have good tools for identifying those, and also understanding why the majority of patients aren't benefiting from the addition of immunotherapy. So a lot of research is looking at that immunosuppressive tumor microenvironment. Hopefully, if we understand those mechanisms of resistance, it will allow more rational combinations where immunotherapy, I think, will have potentially the greatest gain. The biggest challenge, though, despite these modest advances in systemic therapy, is still late presentation. Patients are often highly symptomatic, often with poor performance status. Actually, many patients don't get to systemic therapy at all. So I think our greatest efforts are better spent understanding the risk factors, better means of early diagnosis and surveillance. Some of the practical challenges we've heard about in terms of biliary stenting and tissue acquisition, maybe the direction of travel would be liquid biopsy. It'd be interesting to get pathology perspective on the role of circulating DNA in helping some of those challenges of tissue diagnosis, in particularly the challenging hilar cholangiocarcinomas.
So I suppose that there's hope, there's still a chance, and maybe the next couple of years might help us along the way. One question for Professor Dar. You seem to be the main highlight of the show at the moment. There's a lot of debate in the surgical world regarding doing routine extended resection versus non-extended resections, with some people advocating caudate lobectomy routinely and venous resection routinely. 20 numbers is a huge number for a center. I think we do around 6 a year, so it's not as much as you guys do. But what's your take on the extended versus non-extended resections?
Thank you very much. That's the beauty of writing one paper. You become a subject expert. So I'm humbled. I think in terms of resection, caudate lobe extended versus less, you just need to look at the biliary anatomy. If you look at the confluence, right-left hepatic duct, and the anatomy of the caudate lobe, the caudate ducts are generally 3 to 4, and they're drained on the left side, on the right side, or at the confluence. So that is the anatomy of the caudate lobe. So for a hilar cholangiocarcinoma, if you do not remove the caudate lobe, you are not going to get a cancer clearance. That is the first and the basic thing conceptually. So I personally believe, and the second part related to the resection is based on the anatomy. If you look at the anatomy, the left hepatic duct has a longer course as compared to the right. The right immediately divides into your sectoral duct. That is why once your cancer spreads longitudinally along the ducts, it most of the time involves the anterior and the posterior sectoral ducts on the right. On the left side, it takes a lot of our time. So if you look at the cholangiocarcinoma literature, the best radical treatment is an extended right hepatectomy or a right trisectionectomy, because it takes off most of your biliary tree away, including the caudate lobe, and that gives you a radical cancer clearance. But however, there will be cholangiocarcinoma, which may start from the left hepatic duct and grows medially, and then involve the confluence on the right and the anterior posterior sector. So here you might have more margin on the right side. So I think these extended resections, one of the less reported or less practiced resection, which we try to do, is a central hepatectomy, where you have a true central cancer involving both sides, going up to the falciform fissure on the left and involving the take of the right anterior and posterior on the right. So this is a cancer where you need to actually resect the center. If you go for extended right hepatectomy, you have to do portal vein embolization, you have to wait 6 weeks and all that. So you can preserve the left lateral and segment 6 and 7. That is also influenced by about your invasion of the artery, because the right artery goes just behind the confluence and the portal vein. So I think There is no textbook answer to a hyalocholangiocarcinoma case. It has to be tailored according to that individual patient's cancer extent, vascular involvement, the future liver remnant, the quality of the future liver remnant, the volume, and obviously the degree of stasis and all that. And then as a patient, as a whole, if you we do see very young patients here. If you look at the Western literature, most of the cholangiocarcinoma is actually in the 6th, 7th decade. Here we do see patients in their late 20s and early 30s. So I think all these factors has to be put into the consideration for planning. Thank you.
Just a comment from me, actually. I think from this discussion, 3 themes are coming up here. The first one is about accurate data collection in our local context, because we feel we don't know much about the disease here. My own personal experiences, I've seen people are younger here as compared to Western population when they present to us with more aggressive disease. So role of registry is going to be important. The second theme I think is coming up is treatment of these patients in high volume centers. It's not a job for an occasional surgeon just to do hyalocholangiocarcinoma every 2 years or so. So that education has to be given to our trainees, how that referral should be done to high volume centers rather than holding the patient to themselves. And third is cross-specialty education. We have talked about role of ERCP, when not to be done and when to be done, and for early referral. So my question from all the audience is, what are the steps to be taken to educate all the doctors that these patients should be referred very early to high volume centers, and then especially to other specialties like gastroenterologists, to say that these patients should be discussed in multi-center meeting immediately, because as I think Faisal has mentioned in his talk, that these patients are stented immediately as they reach gastroenterologists and then referred. So any comments or suggestions how we can spread this education?
I think this is one effort where multiple disciplines are being represented. And I think we need to ensure, I think this is one action or leverage point where you can take is just these conferences and regular MDTs. These are the 2 things so I think the key is MDTs. So either you do it weekly or online. Now we have digital technologies to assist us. I think that is the key. To me, this is the key.
I personally think as HPB is growing as a specialty in Pakistan, things will change. It's taken some time. I think centers like PKLI and Gambard have done a marvelous job with the training, especially with the CPSP program coming in. I think that's going to change the landscape for HPB significantly in the next coming years. Cholangio is a hard disease to manage. I mean, even if you go to the Western world with their different age group, it was difficult to manage there. I think we probably need to have more collaboration, like the professor said. I think that's very important because there are only a few organizations. You can only manage cholangio in an organization. I don't think you can manage it at individual levels. It has to be an organization-led service. And we probably do need to push a bit more in conferences, symposium, workshops, collaborations, because our population, like Professor, is young. The average age that we see here is between 25, 30, 40, 45. So very, very young patient. Recently, we did a patient who was 26. So very different pathology, very different age group. And I think that in a way, our age group is younger. So we may be able to be more aggressive with them in terms of the surgical side, unless the oncologists come up with something which puts us out of a job.
I think just one comment will be, I feel quite strongly that there's a strong genetic component to this cancer also in Pakistan because of our unique genetic pooling in the country. So at PKLI, we are setting up a different type of projects to look into that. Genetic testing is not available in Pakistan right now, but I think that's an area forward which we need to look into because I think we are dealing with a slightly unique disease than we see in the West.
And we see this across all specialties, pancreas, gallbladder, liver. You see this across the whole spectrum of HPB. Our median resection rate in UK was for a 60-year-old in pancreas. Here it's 35. So it's a different pathology altogether.
So regarding the comment that you've passed, I would rather suggest, considering this to be a top-to-down approach, I would suggest a bottom-up approach in which we should educate our junior doctors in the tertiary care hospitals in public and private sectors. Because what I feel is our junior doctors at the moment are not very much aware of surgical burden that we are going to face in the coming years. So my suggestion would be bottom-up approach, where we can organize small symposiums and seminars in periphery hospitals, in tertiary teaching hospitals, making our junior generation of doctors more aware of the oncological burden or cancer burden that we might face in coming years, sir.
Agree. Any more comments from the audience?
Yeah, I think we need to close this. Sorry, I joined a little bit late, but I think I learned in these last two talks. I learned a lot, and hopefully all the audiences must have learned. I think our main focus is on patient care, but my message is that when you go higher and higher, you see the bigger picture. And the bigger picture is we are actually acting on the passive wisdom of the West. Our disease is different. Our circumstances are different. Our infrastructure is different. So we, as an experts, don't try to implement everything which the West is saying. Need to understand our own local circumstances and develop strategies for local problems using local solutions. Unless we do not do this, we will not be coming up to the real challenge is to meet the needs of the society, right? And the society segment has to be the bigger one to get the benefits of. So thank you so much for coming today. And I think it was a great session. Thank you so much.
Thank you very much, Professor Palmer. Thank you, Professor Dar. Thank you, Professor Savar and Dr. Mudassar. Thank you.